Colon and rectal cancer can affect anyone, not just those with a family history. It can affect men and women, the young and the elderly, and you and me.
Fortunately, there are steps we can all take to reduce our risk for colon and rectal cancers.
And on this week's Health Talk, Dr. Jim McLean, a highly respected colorectal surgeon, will tell you what you need to know about colon and rectal cancer and their prevention.
And detecting them in their most curable stages. So stay tuned for this very important show.
We're up next. Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. We have an important topic for our show today, colon and rectal cancers, their prevention and early detection. Our guest is Dr. James McLean. He's the Chief of Colon and Rectal Surgery at Norwalk Hospital.
Jim, thanks for joining us.
Thanks for having me.
And having you back.
Thanks
So this is a very important topic. It's a major killer of men and women, and things are changing. So tell us about what's changing and what's new in colorectal cancer.
Well, so as you said, colorectal cancer is very common. It's actually the second most common cause of cancer death, and if you include skin cancer, it's the fourth most common cause of cancer diagnosis in men and women. In terms of epidemiology, I mean, one of the things, we can talk about are the standard risk factors. One of the things we are seeing, however, is that the risk of colorectal cancer is increasing at an alarming rate in young patients younger than 50. And in fact, just in this past year, that report came out where they compared patients born in 1950 versus patients born in 1990. The patients born in 1990 have twice the risk of developing colon cancer and 4 times the risk of developing rectal cancer.
This is over their lives, or even
over their lives.
Wow.
Exactly. So
do we understand why this risk is going up?
We don't, and that's obviously an active area of research. We're trying to figure that out, and there's probably various factors. Colorectal cancer in general has lots of factors that go into its development, whether it's genetic, whether it's environmental, sporadic causes. So it's certainly something that we're looking at.
Tell us a little bit about some of the background. So colon and rectal cancers, and you split them up a little bit. They're not exactly the same.
That's true. So we can talk a little anatomy. The colon is about 5 feet long. The rectum is really the last 6 inches or 15 centimeters. In terms of epidemiology,
Just so you say, people may know the colon is a large bowel.
Exactly.
It's a big diameter bowel that
Exactly.
takes the water out of the stool, and it sort of holds it there until you defecate.
Exactly. That's sort of the main job. And again, the rectum is that last 6 inches, which is sort of a specialized area, and that contributes to defecation, obviously. So in terms of epidemiology is fairly consistent. Risk factors are fairly consistent. It's really the treatment, which we'll talk about later, where things kind of change in terms of how we manage colon cancer as well as colorectal cancer, or compared to rectal cancer.
So what are some of the risk factors?
So risk factors, there's family history is obviously important. About 30% of patients with colorectal cancer will have a family member who's had, or first-degree family member who's had colon and rectal cancer.
And that means a mother, father, brother, sister, sometimes a child.
Exactly. And so family history is important. Obviously, a personal history of polyps. Polyps are the precursors. These are the lesions that develop into cancer. So if you have a history of polyps, that's a risk factor for colon cancer.
And just so everyone doesn't faint at home, there are several kinds of polyps, and there's one kind that doesn't seem to be a precursor of cancer, the hyperplastic polyp. But
that's true. That's true. Adenomatous polyps are the ones that are precancerous. So even in the realm of benign polyps, there are some that are certainly more precancerous than other ones. So not every, again, like you said, not every.
So if you have a question, you should definitely ask your doctor about that. But in general, we believe that many or most colon cancers start as benign polyps.
Exactly.
True.
Other risk factors are, or we can talk about lifestyle factors. So in terms of diet, high-fat diet, low-fiber diet, we think increases the risk for colorectal cancer. Sedentary lifestyle is a risk factor. Smoking is a risk factor, not to the extent of lung cancer, but it certainly is a risk factor for colon cancer. And even alcohol, to some extent, increases the risk of colon cancer. Now
it's remarkable how the same things keep coming up, no matter what the disease. We hear about smoking activity, lipids, and diet and weight.
Exactly. And then the last thing to mention, and this is sort of another topic, but there's something called inflammatory bowel disease, ulcerative colitis, Crohn's disease. They're sort of cousins to each other. That's sort of a chronic inflammatory disease, and if you've had that for many years, that increases your risk for colorectal cancer as well.
That's one of those other things we hear a lot about, is that chronic inflammatory conditions can sometimes lead to other processes down the road, and this is certainly one of those.
Which actually makes a lot of sense to me, because we know that most cancers are an accumulation of mutations, genetic changes, and those often occur at the time of cell division, and when you've got inflammation, you have accelerated cell division, so
Exactly.
it makes lots of sense.
And when you think about these risk factors, particularly ulcerative colitis, Crohn's disease, that determines of how often we screen patients and how often or how early you may start doing preventative studies such as colonoscopy, which we can talk about. So when you talk about screening, the idea is to sort of find cancer at its earliest stage, or even more so in colorectal cancer, find these lesions before they have a chance to develop into colorectal cancer. So that's where colonoscopy comes in, where we'll do these studies and examine the large bowel, examine the colon, and try to find these polyps, remove them before they have a chance.
Now, right now, the recommendations for colonoscopy start at age 50 for the average risk individual. But there's some we recommend earlier colonoscopy. Do you want to say a few words about that?
Sure. So average risk means no family history, no personal history of polyps, and as you just said, we start screening those patients at age 50. Now, if you have a family history, if you have a first-degree relative, parent, sibling, child, then the recommendation really is to start at age 40 or 10 years younger than the age at which that relative had cancer. So, for example, if a patient's father had colon cancer at age 45, that patient should really start being screened at 35. In African Americans, the recommendation is actually to start screening at age 45 as opposed to 50. And again, we talked a little bit about the inflammatory bowel disease. Those patients you may start screening earlier as well.
And one of the things about colonoscopy, just to highlight for our viewers, is that colonoscopy can be not just detecting a lesion, but really you can remove the polyp that would have been destined to, we think, to become cancer down the road. So it can really prevent that cancer.
Exactly. So as opposed to some other preventative studies that you're doing, again, you're not only looking to find cancer at its earliest, most curable stage, you're actually finding these polyps before they have a chance to develop into cancer. So
which is really different than many of the other screening type tests that we do. We know pretty definitively that most colon cancers come from polyps. There are also some DNA tests that you can do on the stool.
There's something called Cologuard, which has been around for a couple of years, and that is it's certainly more sensitive, more accurate than, say, just examining the stool for blood, which has been around for many years. And so Cologuard has a role. I mean, certainly for patients where maybe there's some risk to doing a colonoscopy. If the patient adamantly does not want to have a colonoscopy, it's a way to do some screening as opposed to just doing nothing at all.
And again, just to say it explicitly, the reason to do screening is that in early stages or in polyp form, those are not symptomatic lesions. So you're not waiting until you develop symptoms, and we can talk about what some of the symptoms of colon rectal cancers are, but you're trying to get things when people are still feeling well and they're really not having symptoms that would trigger them otherwise to see a doctor.
Absolutely, yeah. So we'll go over the symptoms, but like you said, that's a great point. You may not have any symptoms, so by doing these preventative exams such as colonoscopy, you can either prevent it, or if you happen to catch it early, you can catch it at a curable stage. That's the other message, is that colon cancer is certainly at the early stages, it's curable. I mean, the earliest stages have survival rates in the over 90%.
So even if you're 50 and at average risk and your doctor says you should get screened, even though you're feeling great, you should really get the screen.
Absolutely.
And we should say something also more about family history, that if someone has colon cancer at a young age, that's much more, a very young age, earlier than 50, that's much more likely to be a genetic form of colon cancer, and the possibility to be passed it on is higher.
Absolutely. So again, about 30% of patients will have what we call familial colon cancer or colorectal cancer, where they have a first-degree relative. About 5% of patients with colorectal cancer will have one of the hereditary genetic syndromes, and there's really two common ones. There's something called Lynch syndrome, or hereditary non-polyposis colorectal cancer, and then there's FAP, which is familial adenomatous polyposis. So Lynch syndrome, the interesting thing about these patients, and the thing that it's really important to be aware of, is that these patients, there's a link between colon cancer and about 6 or 7 other cancers. So patients with Lynch syndrome have high incidence of uterine cancer, ovarian cancer, small bowel cancer, gastric cancer, pancreatic cancer. So again, if you have a young patient who has one of these cancers, and certainly if they have a family history with siblings or parents or children with these same types of cancers, then there's, we can test these patients. We can actually test for genes. We can get them hooked up with genetic counselors and sort of find out if they actually do have a gene.
And that's a really
That's really
important point. I think if you have a strong family history, you should see a genetic counselor and then decide with the counselor about genetic testing.
Absolutely, because the screening may be different. You can test their family, the relatives. If one person has the gene, then the first 3 relatives have to be tested. They may have it, and that may have implications in terms of how early we start screening and how often you start screening.
That's really important.
And there have been some changes in the frequency, the epidemiology of rectal cancer. Maybe you could go, we have about a minute and a half left.
Exactly. Like we had touched on earlier, we are finding, and we don't know why, but we're finding that the incidence of rectal cancer, colorectal cancer in general, particularly rectal cancer, is increasing in younger patients. And the important thing is that, these patients aren't routinely being screened, particularly if they don't have a family history. So the main point is that if you're a young patient and you have any of the types of symptoms, such as bleeding, change of bowel habits, thinning stools, anything like that, you should certainly talk to your physician and at least think about getting screened or getting worked up.
And so. The patients who are going into their 40s and start thinking, well, maybe this is just part of the aging process, don't maybe assume that. But if you have bleeding, that's certainly never normal. If you have a change in your bowel habits, get that checked out.
Absolutely. Again, screen at 50, but any of the other symptoms really should not be ignored and should be.
Should we be thinking about doing rectal, since a lot of the rectal cancers can be palpated with a rectal exam? Should we be encouraging rectal exams on younger patients?
Well, I think that's a good idea. I think the general guidelines haven't changed yet, but if this new evidence where this incidence is increasing in younger patients, perhaps in the future we'll be screening patients earlier, or maybe doing flexible sigmoidoscopies, which is sort of like a short form mini colonoscopy where you're examining the rectum and the sigmoid. Perhaps in the future that may be something to think about in terms of screening people earlier than age 50, even for people with average risk.
So
this is really all very important information. I think people at home, this is a disease which should be largely preventable, both of them, by catching them early. So there is an opportunity to keep yourself from getting cancer.
Absolutely. And unfortunately, we've run out of time for this show, but we'd like to thank Dr. James McLean for coming on Health Talk with us today.
And so if you at home have any questions or comments, please email them to Andrea and me at healthtalk@wchn.org.
Thanks so much for watching.
And stay healthy. And remember, if you're over 50, schedule your colonoscopy.